Good afternoon, everyone. As I said earlier, this is going to be our last lecture before the midterm. You guys will have a midterm next week. It's going to be kind of, quote, my standard drill. There's going to be 52 questions. There's going to be 2 floating bonus questions, and it's pretty evenly balanced amongst the material we've covered so far. So what we're going to cover, and this is going to be the last material that will be represented on the midterm, is we're going to screen sacrum, sacroiliac, joint, pelvis. As you guys probably noticed, there's not a ton of information in the Davenport textbook. There's actually not even a chapter that's dedicated to it. So a lot of the stuff's going to come out of the Goodman textbook and then your imaging textbook as well. Okay, and to be quite honest with you, there's also not a ton of imaging. There's going to be a lot of screening to this. Okay. So what we need to be able to do as physical therapists is recognize the signs and symptoms, right? We need to figure out, like we've kind of talked about both this semester and last semester, can I see this patient or can I not see this patient? Or can I see this patient, but I think they need something else on top of me? And that's really where a lot of our screening techniques are going to come into. That's where you guys are going over a lot of information in neuro and MSK right now, because that's really a good chunk of the evaluation process. Does this patient belong in my clinic, or may something else be going on? So when it comes to the pelvis, when it comes to SI joint and the sacrum, you will have to ask some comfortable questions. Okay, it's going to happen. You will have to ask questions about bowel and bladder. You will have to ask questions about sexual activity and sexual history. What I'm going to ask you to do is be very respectful to that. So if an individual is adolescence age or older, we're going to assume that there's going to be some sort of sexual activity that's happening, okay? Until you ask that question, they say absolutely not. And even then, and let's face it, let's kind of think about the situation. We have a 14, 15-year-old patient. They're in the appointment with mom or dad. Do they necessarily want mom or dad to know, right? There's a good possibility that they do not. So even if you get the answer no, that might not be the 100% truthful answer. Also, when we're dealing with especially female patients of childbearing age with pelvic dysfunction, with abdominal pain, with pelvic pain, we also need to consider the good possibility that there may be a pregnancy involved, especially an ectopic pregnancy. And we'll cover that one a little later. So we need to be very, very cognizant, and we need to be very respectful, but we also need to explore that sort of history as well. So SI joint and sacrum, I'll be quite honest with you, it's kind of a pain because, as we know, there's not a ton of movement there. So it's not like we can have our patients do something like repeated motions and all of a sudden the SI is going to flare up. Sometimes it does and sometimes it doesn't. Because of the proximity of the SI joint to a lot of different other structures, both MSK in nature, vascular in nature, reproductive in nature, GI in nature, right, urogenital in nature, there's a lot of stuff going on right in that little spot. Think back to your cadaver dissections last year. When we dissected out the pelvis, there's a lot of stuff down there, isn't there? Every single one of those structures can be a source of pain. That's all going to present as pelvic pain. See the problem? So SI joint pain can be referred from a lumbar disc, right? I can have something like a radiculopathy that refers down to the SI joint. Spinal stenosis can do that as well. I can have some sort of facet joint arthropathy that refers into my SI joint. Or I can maybe have a hip disorder, right? Let's think about this. My patient comes in, they have hip OA, they have an altered gait pattern. There's a very good likelihood that they're going to have quadratus lumborum overactivity or something else that's going to present as SI pain, even though the underlying condition is really hip OA or an altered gait pattern. So this is kind of where you need to play a little bit of a detective role. Most commonly, what you're going to see, if it is true SI or sacroiliac joint pain, again, we're going to have a mechanism of injury. They're going to step off a curb wrong. I see this one all the time in the clinic. They're going to fall and they're going to land on the rear end. Or they're going to lift a heavy object. And we see this more and more because of the nature of our economy and the nature of the fact that we have folks doing jobs that they're not necessarily physically, I won't say able to do, but not conditioned to do. If they're lifting a heavy object in a twisted position, that's going to increase the likelihood that they have some sort of SI problem or sacrum problem. A common one I see are folks in office settings lifting boxes of copy paper, right? That's a really common one. Why? Because typically that work, occupation, task is not done very often, is it? Once every other week, right? Or those huge things of like water, these huge jugs of water. That is a very awkward position that it takes a lot of physical demand, and typically it's being done by someone who does not do that job very often. So be very, very conscious of that. When it comes to referred pain, what's most commonly going to refer to the sacrum and the SI? Endocarditis, and that's not really that common. Prostate cancer is a big one. Other neoplasms, bladder cancer, things like that. That's going to be very common. Gynecological disorders, obviously based on the proximity of fallopian tubes, uterus, ovaries, very common. Rheumatic diseases that will target the sacroiliac joint are also very common as well. What do I mean by that? Ankylosing spondylitis is a rheumatic disease. Reiter syndrome, which we're going to get into just a little later. Psoriatic arthritis, things like that. Paget's disease is a metabolic disorder. And literally what happens with Paget's disease, and we're going to look at some x-rays later on in Paget's disease specifically. As we know, your bones are always going through a breaking down repair cycle. What should happen is I should lay down as much new bone as old bone goes away, right? Kind of an even swap. With Paget's disease, what happens is that much more bone is taken away than new bone laid down. So literally the breakdown of bone is faster than the recycling or laying down of new calcium. You can kind of think about it, what that will lead to is going to be a pelvis that's not going to have a ton of radio opaqueness, is it? Right? That's going to be a very radiolucent pelvis. If we kind of think about it, the pelvis should be one of the densest spots of bone in our body, right? It's bearing a lot of weight. Therefore, there should be a ton of calcium in that pelvis. The pelvis should show up pretty bright white on an x-ray. If we look at that pelvis and we can see through it on an x-ray, that is a problem. Because what that means is that there's not nearly as much calcium in that pelvis as what there should be. Obviously, that's going to lead to things like hip fractures, other pathologies as well. This chart is straight out of the Goodman textbook. This is a nice little chart for all the little different systems that could refer to the sacrum and to the SI joint. So as you can see, there's a ton of stuff here. Now, what I want you to do when you look at little charts like this, and the Goodman textbook has a ton of these, the Davenport textbook has a ton of these, all of these are going to follow the same basic rules that we've already talked about, right? So things like associated signs and symptoms. If my patient has SI pain or sacral pain or pelvic pain, and I ask them what the ags and the eases are, right? So I go through my sins, what makes it better, what makes it worse. Oh my gosh, every time I have a bowel movement, it gets totally worse. It's probably not an MSK problem. It could be based on other objective findings, but more than likely, it's something like a rectal problem, right? Or a colon problem. If my patient's having pelvic, SI, or sacral pain, and I ask them, when does it get better? When does it get worse? Wow, when I have my menstrual cycle, it's totally worse. It's probably not MSK. It's probably something that's going on either in the uterine lining, something like endometriosis, pelvic inflammatory disease, or something in the reproductive system. Okay, so we need to be aware of these patterns. Remember, we kind of talked about that all the way last year with anatomy. One sign, one symptom tells you nothing. Establish a pattern, you're going to get a lot more information. So again, simple rules here. If someone does not know how they got hurt, that is automatically a red flag. You can't tell me why you're in my clinic, and you can't tell me what hurt you. The antenna go up a little bit, right? The spidey sense goes up a little bit. Why? Because I now have suspicion that this might not be neuromusculoskeletal in nature. Even if they do have a mechanism of injury, that does not clear them that it's definitely not something else. And I'll give you an example. Ms. McGillicuddy comes in, she's 86 years old. She fell down in her living room and she broke her pelvis. Does that mean that Mrs. McGillicuddy only has a pelvic fracture, or could there possibly be something else going on? Right? Is the osteoporosis an MSK problem? Or is it a metabolic problem? I'm going metabolic, right? Metabolic etiology, MSK presentation. Okay, see the difference? So even though my patients may fall, break a hip, break a pelvis, whatever it is, they still may have an underlying pathology. Can I see how it works? Now, also what can help you in terms of fracture, and especially pathologic fracture, is not necessarily just focusing on that one fracture. Who in this class has heard the term frequent flyer used in the clinic? What is a frequent flyer? Because we're not in the airline industry. What is a frequent flyer? They come all the time, right? I call them repeat customers. I've also heard repeat offenders, frequent flyers, right? They're all common terminology. If someone's coming to you and they've had a sacrum fracture in May and a femoral neck fracture in July and an ankle fracture in September, is it possible there's something else going on too? Heck yeah, right? Now, don't get me wrong. That person just may have had a really, really bad year, right? Because this stuff happens. But we also may be dealing with and at least have enough evidence to say, I think this person needs a bone scan to determine if osteoporosis is present or not. Because if it's not, no big deal. You didn't make a wrong decision. You made a right decision by screening. But if you miss it, that person is going to have more severe fractures later on, and a greater number of fractures as well. So you have to be very careful with this. So also take a look at when we're looking at patterns, especially when we get into radiation of pain, where does it refer to? Does it go up or does it go down? Or does it go laterally? So think about this. If I have low back or sacral pain, and I'm getting this weird wrapping around the flank of pain, it's very possible that that's kidney stone, especially if I have aggravating pain with urination. Right? If my back pain gets super duper bad when I urinate, it's probably not erector spinae. Fair? If I have pain that radiates down into the buttocks, I may be dealing with something more vascular in nature. Think about, and I'm going to bring back a horrible memory, I apologize. Think about drawing out the blood supply of the pelvis last year. Hannah literally just shuddered. That was funny. We just did that anatomy on Wednesday, by the way. I didn't see you in there. So just be aware of the referral patterns, not necessarily just ags and eases, but where does it refer to? Does it go superiorly? Does it go inferiorly? Right? Because here's what's going to happen. I'm going to have a patient come in, and the diagnosis, the script is going to say sciatica. Right? So why is it sciatica? Well, because it kind of starts here and kind of moves here. Right? So a lot of primary care physicians are going to say, well, that sounds like sciatica. It may not be true sciatica. It may be something else. It may be something vascular in nature. It may be something GI in nature. It may be something else based on referral patterns. Again, another box out of the Goodman textbook. When looking at red flags, these are really, really good things to know. Remember, previous history of cancer. That's a huge one. If I have a previous history of cancer, I have an increased likelihood that the next event is oncological in nature. Not definitively, but an increased likelihood. If they have previous GI disease, right? If they have ulcerative colitis, if they have something like IBS, irritable bowel syndrome, are there other risk factors involved? Do they have a confirmed diagnosis of osteoporosis? Do they have a confirmed history of IV drug abuse? Right? All these things can lead to maybe this is not an MSK problem. And then when looking at the clinical presentation and associated signs and symptoms, those are all the same rules we've been talking about since last August. Right? Again, lack of objective findings. If your patient has full range of motion and full strength and nothing you do, you throw every test that you guys learn at MSK, right? Galeson's test and Yeoman's sign and all this stuff, and you're cranking that pelvis 6 ways from Sunday, and you're not eliciting anything. My question for you as your clinic director would be, what are you working on? Why are you having this person come back in the first place? Right? So something else is probably going on. And then associated signs and symptoms. What else is going on? What else is eliciting pain? A lot of times, your patients are going to know what's going on, but it's going to be your job to connect the dots. So typically with SI pain, big things to watch out for. It can be unilateral. It also can be bilateral, okay? Because you kind of think about it, the sacrum is a fused big old bone. I could have some sort of SI joint dysfunction that refers pain or has pain on either side. I also can have SI pain that show me the patterns of something that's more disc in nature or something like kidney disease. The big things we need to watch out for here, and this is the fun little one, If I have centralized pain while I'm transferring sit to stand, that's more likely to be, not definitively, more likely to be discogenic in nature. Why? Think about the pressure increase that happens when I transfer from sit to stand. So again, these are very simple questions you ask your patient. Hey, tell me how sitting is. Tell me how standing is. Tell me how, when you transfer from sit to stand, what does that look like for you? If they have more pain transferring sit to stand, you may be dealing with something more discogenic in nature versus a true SI problem. When it comes to infection and inflammatory SI pain, the SIJ is a joint just like any other joint. It can get infected, it can get inflamed, all that stuff can happen. Associated signs and symptoms are going to be very key here. Right? So if I'm dealing with an infection, what's one of the outward easy signs that I'm going to see with my patient? Fever, elevated body temperature. Right? When I have elevated body temperature, there's something going on. More than likely, my body's trying to fight off something like an infection. Be very aware of that. Okay? So, a lot of times, patients are going to have a low-grade fever happening, or they're going to have some sort of kind of weird feeling, that malaise sort of feeling. That's not correlated highly with something like an MSK-style sacroiliac joint problem. The thing to watch out here for is ankylosing spondylitis. Okay, remember we talked about that in the lumbar section. Think back to that modified New York criteria. If I have alternating buttock pain, that's not normal, right? If I have pain that is absolutely terrible, second half of the night, terrible when I first wake up in the morning, but I start to move around and within 60 minutes, I'm feeling okay, that's also indicative that there may be something like ankylosing spondylitis happening. So just be very aware of those things. Not saying that when you have criteria like that they definitely do, but if you go through that the modified New York criteria, the more positives I have, the more checks I have in that box, that is going to give me more likelihood that AS is happening. So rheumatic diseases, Reiter syndrome is a big one on this one. Okay, we already kind of talked about ankylosing spondylitis. Reiter syndrome is a big one because that occurs when there is a venereal or sexually transmitted disease active in the system. This is a big reason why when your patients are coming in with pelvic pain, SI pain, sacrum pain, you will have to ask questions about their sexual activity and history. Because if they have a diagnosis of a venereal disease, or you notice on their past medical history they're taking medication for venereal disease, right? Because as we know, and we've seen this all the time with things like hypertension. You ask the patient, hey, do you have high blood pressure? Absolutely not. But you notice that they're on 14 beta blockers. Well, technically they don't have high blood pressure because the medication's lowering their blood pressure, right? Same thing with venereal disease. A lot of people don't want to admit they have it, right? There's a whole social context behind that. But they'll list the medication. So you kind of have to connect the dots again. Reiter syndrome, again, going to be present with venereal disease, okay? When it comes to arthritis that's associated with inflammatory bowel disease, that is very rare. Okay, so do not think that every patient that comes in with SI pain and has inflammatory bowel disease is going to have arthritis associated with that. That is extremely rare. But you could actually see outward signs, such as a skin rash. So just be aware of that. Again, be very thorough. Ask your patients a lot of questions. The more information you have, the better you're going to be at diagnosing this person. These are big risk factors for sacral fractures. Remember we talked about sacral fractures? I will say that the sacrum is a very stable bone. It is a very dense bone. Folks do fracture it. My next door neighbor catapulted himself off an ATV last year and fractured his sacrum. So it does happen, and he's my age. So it can happen. Here locally, military personnel, we're going to see a lot of lumbar fractures. We're going to see a lot of sacral fractures. It is quite prevalent, especially with the folks that are jumping out of airplanes. So just be very, very aware of these things. The big one, and we kind of talked about this last semester, if you guys remember the elbow stress fracture case I had 15 or so years ago. If I see a prolonged history of corticosteroids, I need to really be careful for something like a stress fracture, okay? Because as I have more and more corticosteroid in me, I'm going to have essentially medication-induced osteoporosis that's very local or localized. And I've seen this happen in the past. You know, unfortunately, I've seen some folks who have access to multiple providers. So do you guys know how many corticosteroid injections you're supposed to get per year? 3 max. 4 if you're like, it's really bad, but typically 3 is what you're supposed to get annually. If I see 3 different providers and they each give me 3 different injections, I just boosted that to 9. So it shouldn't happen, but I will say it does happen every once in a while. So just be very careful of this. Paget's disease is a metabolic disease, okay? So the reason I want to cover something like Paget's disease is because, as you can see, it's number 2 on the list below osteoporosis. Again, what happens is that as the bone starts to go through its recycling process of tearing down and rebuilding, because this is a kind of weird metabolic disease, the bone, number 1, doesn't replace at the same rate as it should. Number 2, it doesn't replace where it should in terms of location. So what you get is this weird kind of outcropping of the bone. It just kind of goes all over the place, but no one spot is strong. So the bone gets weak, it gets spongy, it gets deformed. There's redness in the area a lot of times. If you think about it, if I have this kind of big outcropping on my iliac crest, that's going to push against some soft tissue at some point. Right, that's going to hurt. That's going to cause an inflammatory process. And then if I have a very weak pelvis, it's not going to be able to withstand my body weight at some point in time, or a traumatic event like a fall. When it comes to fractures, again, like I said early on, look at the history of fractures. A great question to ask patients, and I ask this to all my evaluations. How often do you fall? Okay, because number 1, that can tell us something like balance problems, vertigo, Parkinson's, some sort of somatosensory issue, whether or not that's diabetic related or not. How many fractures have you had? How many falls have you had? How'd you get here? Tell me about the injury. We're going to see traumatic fractures happen in pretty traumatic events. Like I said, my neighbor catapulted himself off an ATV. I saw patients here recently, their vehicle got rolled 4 or 5 times. So there's some pretty traumatic accidents you're going to see. Trauma-related stress fractures. What we need to watch out for here is trauma-related stress fractures in the young athletic person. Older adults with osteoporosis, absolutely. What I want you to consider, and I see this happen with my young athletes a lot, 12, 13, 14 years old, what process happens? Puberty, adolescence, right? Who here went through a tremendously large growth splurt about 12, 13, 14 years old? Yeah. What'd you say? Oh, ouch. Ouch. Oh. It's okay. It's okay. Yeah, and here's the honest to God truth. Okay. So you are less likely to have a back injury from catching a patient. And do you know why? Because patients don't fall up, they fall down. Right? So, I mean, I don't see a lot of patients that are taller than me. Right? So they're all below me. So I've gotten very good at dropping my hips under their hips. So you're already in good position. That's okay. So with our young athletic persons, our young athletic population, this is a really big one, right? Because, and I've seen this one with SI problems. I've seen this one with foot problems. I've seen this one with shoulder and knee and all sorts of fun stuff. Tremendous growth happens in adolescence. In fact, it's the second biggest period of growth in human life cycle. The first one is during the fetal cycle. In addition to that, what we see is that athletes start specializing, right? So, and I see this a lot happen in athletes. They will start lifting, start conditioning, start running, start doing stuff. The play time or the sport time goes up exponentially during adolescence. They're also growing at a tremendous rate, which kind of leads to a recipe for not necessarily every athlete's going to get a stress fracture, as we know, but we do see it happen quite often. So I want you guys to be really careful of that. So when it comes to an insufficiency fracture, literally, this is where we need to really get a sense of how did you fracture. If it's not an appreciable height fall or appreciable trauma, that should be a red flag, right? If I got up out of bed and I fractured my hip, that's not normal. Either I have the strongest quads in the world or there's something wrong with my bone. Be very, very careful of that. If you suspect a pathological fracture, something like osteomyelitis, something like multiple myeloma, we need to get that person in for an image. Sacral fractures, like I said, are tough because they present in so many different ways. Keep it simple. That's my advice, is keep it very, very simple. If they have new onset of buttock pain, new onset of sacrum pain, and you don't know what's going on really, that's kind of a red flag. If they start having pain 1 to 2 weeks after a multi-level lumbosacral fusion, that's a problem too. Let's think about that, right? I shouldn't have anything outside of postoperative pain, soreness, whatever, if I just fuse my lumbar spine and my sacrum. If I start having a ton of sacrum pain after they've done that fusion, there's a good possibility one of the screws backed out. That's a problem. I don't want to put that person on the treadmill, right? If I have a patient with hip, low back, sacrum, groin, or buttock pain, I may have a fracture as well. So just be very, very careful for that. And then understand that if that patient, yes?
How often do like those screws back out?
In my career, I've seen it once.
So it's like very rare.
It's very rare, and it was a humeral fracture that did it. And the only reason I knew that the screw backed out is because the patient came in and goes, "Hey, I think the screw backed out." I went, "No." He goes, "Let me see your finger," and you could feel the head of the screw coming out. And I'm like, "I think you're right." So yeah, I've only seen it once, but is it possible? Yeah, it's possible. Now, what I have seen, I actually had a guy, he came in for low back pain. This was when I was working in urgent care. He was a truck driver and he was undoing the rig and he felt the chutes pop in his back. And I'm like, that's kind of weird. So doc sends him down to me for some modalities and some just real basic exercises. He goes, I had the surgery done when I was in the Army and I was in Germany. And it feels like the wires came loose. And I'm like, okay, that's kind of weird. I said, well, have they done x-ray or anything on it? He goes, no. So I went down and talked to the doc. I said, hey, here's what the patient's describing. Can we go ahead and get an x-ray on this guy? He's like, yeah, sure. So we get in there, and the guy was right. He had these wires that literally came back posterior, like where spine's process was, and they popped loose. So you can literally see all these fragments of wires in there. I'm like, I'm really glad we did an x-ray. Yeah. So yeah, he went to the hospital like now. So moral of the story is when your patient says, hey, I think this might be going on, it actually may be going on. But that's only a couple examples. When it comes to GI etiology will have GI associated signs and symptoms. Now, here's what I'm going to tell you. And this is going to be another one of my horrible stories, right? So, had a patient, seeing this guy for the rotator cuff. They did a surgery on him. Guy was about 8 weeks out, and he disappeared off the face of the earth. Didn't see him for a couple months. He came in a month after that and goes, hey, I need to talk to you. So we go back in the room and talks to me and goes, I had a colon rupture. I was like, really? And he actually had a colonoscopy back. And what has happened was that his pain medication that was prescribed for his rotator cuff, because it's an oral medication, therefore it goes everywhere, masked the fact that he had a colon rupture. He had a very small colon rupture that eventually one morning bursted and became a very large colon rupture. He had GI signs and symptoms that he didn't tell anybody about for a while because he didn't want his wife to worry or whatever it was. So he had blood in the stool and things like that and just didn't tell anybody about it until literally one morning he literally said, it felt like my guts were ripping out, and because they were. So moral story is, I don't care what that patient is there for. Ask them, be very thorough. Are you having any bowel bladder problems? I don't care if that person just had rotator cuff surgery or not. Ask them those questions. Okay? So again, GI causes or GI etiology of SI pain, we're going to have GI associated signs and symptoms, right? So problems with urine, problems with defecation, whether that is painful defecation, abnormal defecation, or something like blood in the stool. Now, when it comes to tumors at the SI, they are rare. Primary sacral tumors include benign, malignant growths and account for less than 7% of all spinal tumors. Now, take that information and map it onto how prevalent spinal tumors are in the general population. Remember I said everyone's got that one story, right? Everyone's got that one case because they are 2% or less of total low back patients. So when it comes to SI, that is 7% of 2%, right? My math's not real good, but that's a lot less than 1%. So that's my point, is that this is not going to be very common. This is going to be extremely rare. However, again, if that patient's having all those red flag questions, change in weight, bowel bladder problems, unrelenting night pain, things of that nature, they need to at least be screened. We never, ever, ever want to let cancer walk out the door. So if that person's having those sorts of signs and symptoms, absolutely get them screened. When it comes to the coccyx, we're not going to see a ton of this in the clinic. However, what we could see, again, associated signs and symptoms, typically they're going to be localized to the tailbone. If it's MSK, these do fracture from time to time and they do dislocate from time to time. If I have other bowel bladder stuff happening, it's probably not an MSK problem. Okay, that's kind of the moral of the story you get. Those are all the great causes of coccyx pain or coccygeal pain. All sorts of fun stuff. So remember, when it comes to pelvic pain, again, and I understand this class goes through all the weird stuff that the human body can undergo. It is what it is. Remember, and this is what makes clinical practice a little tough, you guys will go years without seeing a single one of these. Okay, remember, I'm in year 20 now, and I can count on one hand how many times I've seen stuff like this. So you will go years, you will see MSK-related pain after MSK-related pain after MSK-related pain until you guys are class of 2024. So about the year 2042, you guys will see one of these. Don't worry, you'll still be paying student loans. So again, where am I going to put my wager? I'm going to put my wager on MSK. When that patient walks in, they're MSK until they prove they're not. So point is, don't think that everyone's going to have one of these weird, rare etiologies of pain. Like I've said in the past, keep it simple. It's all about associated signs and symptoms. Okay, that's what makes this really, really easy. It's also what makes it really, really hard. If I can find the pattern, I can find the problem. Right, again, go back to when we discussed anterior compartment syndrome. You guys remember doing that in anatomy late last year? Lots of things cause pain in the anterior compartment. AKA lots of things cause pain in my pelvis. I have all sorts of stuff. Having pain does not tell me much of anything. Having pain and having bowel bladder problems, or having pain and having an abnormal menstrual cycle, tells me a lot more than simply having pain. Right? So we have to layer on all those extra pieces of information and form a picture or form a pattern in our head. So if I have pelvic disease that appears acute with a sudden onset of severe pain accompanied by nausea and vomiting and a fever and abdominal pain, that's probably not SI joint dysfunction. That's probably something like, holy cow, I have a huge infection in my pelvis. Something like a pelvic inflammatory disease, or bladder infection, or a UTI, right? Because I could have a UTI as well. Mild to moderate back or pelvic pain that gets worse as the day progresses could be, not will be, could be, maybe associated with gynecological disorders. So be very, very careful. Again, go back to your MSK notes. We want to live that 24-hour pain cycle, right? We want to kind of know how they're doing in the morning, the afternoon, the evening, all of that. Look for the red flags, but don't go searching for red flags. I will tell you that everybody will have something that's a little off. Everyone will have something that just doesn't seem right. Just because that person has a little bowel bladder problem, remember, one piece of information doesn't tell me anything. If I ask my patient, hey, have you vomited in the last 24 hours? That could be everything from I have stomach cancer to I went to that kind of shady restaurant and I'm not real sure they cooked the food all the way, right? We've all been there. So one sign, one symptom not going to tell you anything. I need a cluster. I need a pattern. So if you see something like a urologic sign and symptom or something with a connection with the menstrual cycle, follow that up with more questions. Get some more information. If you see cramping that comes in waves, kind of comes and goes, that could be a lot of different things. But if I have pelvic pain and cramping and abnormal discharge from the menstrual cycle, I could be dealing with something gynecologic in nature, something that they need to go see someone else for. Okay, that's kind of the moral story here. I can see pelvic floor muscle pain go all the way back to anatomy and discussing that pelvic diaphragm, levator ani and pubic rectalis and all those great muscles. Again, I know, great memories. I can see pain a lot of different places. Here's the reason why. Go back to that drawing that we did of the pelvic diaphragm. Think about where a lot of those muscles attach, right? So pubic rectalis attaches to the pubic rami, if you guys remember that. Maybe not. It's okay. But think about where a lot of those muscles attach. I could have pain at any one of those single attachments or all the way through. I also can have neurologic disorders. Okay, so the one big one here, you guys remember the pudendal nerve? You guys remember that? Yeah. Pudendal nerve is going to supply the vast majority of innervation to the perineum. So a big one, if I have pain when I sit on a hard surface, but it's relieved with sitting on something like a toilet seat or one of those little like hemorrhoid cushions, I could have a pudendal nerve block. Not definitely, I could. And here's the problem with pudendal nerve problems. They don't know it's definitely a pudendal nerve problem until they go in and do a pudendal nerve block. If the pain goes away with a pudendal nerve block, then it is pudendal nerve problem, if that makes sense. It sounds weird, but there's a lot of let's trial and error this thing. Same, you guys are going to see this a lot of times in the lumbar spine as well with injections, right? So a lot of times they'll go in and do an injection. And if the symptoms go away with the injection, that's part of the diagnosis cluster. We do that too, right? I mean, think about what McKenzie is, right? Okay, I'm going to do a bunch of flexion, or I'm going to do a bunch of extension, or I'm going to do whatever. The treatment leads you further down the road of the diagnosis. No difference here. Look at history, looking at falling on buttocks, pregnancy, trauma. Look at things like muscle impairments. Okay, again, vast majority of our clients that come in, vast majority of our patients is going to be MSK in nature. If they show me associated signs and symptoms, that's when I need to get really, really concerned. If I cannot provoke their pain, then I need to get really concerned. Number two, what in the world am I going to treat? When it comes to anterior pelvic pain, basically think about the anatomy that's there, okay? I could have L1 or L2 refer pain to the anterior pelvis. It is rare, but here's how it kind of works. Think back to the lumbar plexus. I know, again, great memory. And think back to where subcostal nerve is, and ilioinguinal nerve and iliohypogastric, right? Where all those guys come from. T12, L1, L2, right? So upper lumbar discs. Think about the path that they take, right? They all kind of come around the backside, if you will, of psoas major. If I have something going on in T12, L1, L2, I could have referred pain down the distribution of something like iliohypogastric or ilioinguinal nerves, or something like genitofemoral nerve. So just be aware, kind of remember the anatomy and how the course of everything, because it could lead you to a lot of clues of what's going on with this patient. When it comes to posterior pelvic pain, this primarily is going to be SI stuff. And I know there's a ton on these slides. That's why I'm not trying to read it all, because we'd be here till Sunday. So posterior pelvis, the big one you got to remember is going to be SI. Things like PSISs, things like the sacrum, right? Think about what the anatomy is in the posterior pelvis. I could have an abnormal condition of the coccyx, abnormal condition of the sacrum, or the sacrococcygeal junction if there is a problem with childbirth or a traumatic childbirth. Again, got to do a lot of history taking here. If my patient comes in and I have sacrum pain or coccyx pain, and it's happened for the last 6 months, I need to understand what happened 6 months ago. Oh, well, yeah, I gave birth to my 3rd child. Oh, okay. You need to investigate and ask follow-up questions on how that pregnancy went, on how that childbirth process went. So just be very, very thorough when asking patients these questions. When it comes to gynecological causes of pelvic pain specifically, again, I should have lots of associated signs and symptoms. Big ones we're going to see are things like prolapsed uterus. I could see an issue with the uterus itself, something like endometriosis or pelvic inflammatory disease. Ectopic pregnancy is a big one. As weird as it sounds, about 1% of all pregnancies take place outside of the uterus or outside of the endometrium. This is a big one because a lot of times what's going to happen is that these patients are going to have a sudden, unexplained lower abdominal or pelvic cramping. It's going to happen big. Now let's think about this. We're treating this patient, treating them for low back pain, whatever it is. All of a sudden, they have this sudden, unexplained lower abdominal pelvic cramping on visit 7 of their treatment plan. They're working with tech that day, or tech is taking them through some exercises, or they're working with PTA that day, or they're working with you. At that point in time, I'm not too worried if they're having an ectopic pregnancy or not, right? Because let's face it, if I'm having lower right abdominal pain and happening all of a sudden while I'm trying to do something like step-ups in the clinic, at that point in time, do I care if it's ectopic pregnancy versus appendicitis? No, I don't care. Because what I know is something really, really bad is happening and they need to get out of my clinic, go to the hospital right now. So don't get too caught up on getting very, very nitpicky with emergency situations. Keep it very, very simple, okay? Now, if I see sudden unexplained lower abdominal pain, mild to progressing to severe pain over a couple of days, those both still could be appendicitis, right? The difference in differentiating ectopic pregnancy versus appendicitis, you guys remember rebound tenderness for appendicitis? I'm not going to see rebound tenderness for the ectopic pregnancy, right? In fact, I'm going to see maybe pinpoint palpatory pain. So if the pain gets better when I push in and then increases drastically when I take my fingers away from McBurney's point, that's probably appendicitis. If pain gets a lot worse when I push in and gets a lot better when I take my fingers away, it's probably not appendicitis. This is another good box to know. This is straight out of Goodman's textbook. I've tried to include a lot of these. That way it kind of cuts down on the reading, because I understand. I had Goodman's textbook when I was in school, and it's a lot. When it comes to pelvic inflammatory disease, this is a big one. We're going to get into this one a little more, simply because it is very, very common. Tell you what, let's go ahead and let's take 5 minutes. You guys okay? We good? Okay. Because I just heard otherwise.
What I would tell you is, this semester has some unique challenges. It's always fun watching how that really is. But you get that notification full-time clinician, having to like use the weekends to yourself, and then you come right back here crazy.
Doing experiment.
This sucks. It's kind of like, it's almost a senior right.
Probably.
I'm sure you guys have. Oh, gosh. I see.
We still, I don't even know, so you're asking me like class.
I saw it. It's pretty great. They put it back and I'm like, no, this ain't happening.
Yeah, I'll probably be going next week.
Oh, yeah. Very nice.
This weekend. Missing
Oh, yeah. This is weird. Oh, you come and see him. There's no difference. It's just they're different tests. I mean, to be quite honest with you. Oh, if you guys haven't noticed, your hand in the hole, you can see the stand test. It was 500 and one round was that there's tons of thousands of ways to test anything. Basically, you're going to name the literature for the rest of the time. Make a test. Make a test. It's so, yeah.
All right, guys, let's plow through the rest of this and get you guys off to MSK and then your weekend. All right, so when it comes to pelvic inflammatory disease is a big umbrella term. So this is going to envelop things like endometriosis, tubo-ovarian abscess, pelvic peritonitis. Pelvic inflammatory disease is a bacterial infection. Understand it's a bacterial infection. Therefore, it's going to be treated with an antibiotic. This is another one of those scenarios where what will happen first is they're going to give them an antibiotic. It's not until the antibiotic works that they truly know that it's a bacterial infection, right? So this happens a lot in medicine. This happens a whole lot. Understand risk factors of pelvic inflammatory disease. This is where, unfortunately, you're going to have to get a little personal, folks. If they're showing you signs and symptoms, or they're giving you enough suspicion that it could be something like endometriosis, you may have to explore their sexual history, such as number of sexual partners, new sexual partners, past history of venereal disease or STDs, or something like the use of a cervical barrier, aka a diaphragm, or something like an IUD. Okay, there are several cases where the implantation of an IUD has caused pelvic inflammatory disease, either through bacteria that's introduced, everything to just irritation of the uterine wall. So what we're going to see is abnormal discharge and bleeding. It could burn with urination. They could have painful intercourse or painful menstruation. Again, if my patient's telling me those things, but they're here for back pain or SI pain, it still could be back pain or SI pain, right? But they may also need to go see an OB/GYN in addition to me or instead of me. So we do have to have these conversations with patients. And like I said, sometimes they get a little uncomfortable. When we get into peripheral vascular disease, we kind of covered this already with our low back or lumbar section. Peripheral vascular disease in terms of pelvic pain is specifically going to be pelvic congestion syndrome. And that could be an abnormal enlargement of veins or other associated vasculature around reproductive organs. It does happen. So peripheral vascular diseases, associated signs and symptoms are going to be just like every other vascular disease we've seen so far this year, right? If I have throbbing pain, what throbs in the body? The vascular system throbs in the body, right? That's what's going to happen. So again, a lot of associated signs and symptoms here. We could have arterial occlusion as well, right? Again, think back to all those great little artery drawings we did in anatomy, all those anastomoses and all that fun stuff. We can have occlusions at any one of those spots. Now, clinically, if I think an occlusion is happening, I'm not going to spend a ton of time to figure out what anastomoses are happening around the pelvis, right? What I'm going to say is, hey, patient, I think you need to get to the hospital, and I think we need to do something. When it comes to pelvic peripheral vascular disease, females after menopause, postmenopause, will have an increased likelihood of having peripheral vascular disease in the pelvis. When it comes to peripheral vascular assessment, and I understand this box looks like a ton of stuff, this is going to be really super basic, right? I mean, let's think about it. If I have arterial insufficiency, then I'm going to have decreased pulses, the skin's going to be cold, clammy, shiny, there's going to be decreased hair growth, right? All those real basics. That's all this box is saying. So again, just sit back sometimes and think about, where does that artery go? And what would happen if that artery didn't work? Same thing with the venous system, right? Think about, well, if I don't mind getting blood back out of an extremity, what sort of signs and symptoms would I see? Obviously an enlarged leg or enlarged foot, discoloration, things of that nature. When it comes to cancer, in terms of pelvic pain, we can see a lot of these, okay? And I'm not going to say that you're definitely going to see a ton during your career, but it is very, very possible. Again, it goes back to red flag signs and symptoms. So be very, very thorough when you're talking to your patients. Ask questions. So ask questions on history, ask questions on OB/GYN stuff, ask questions on bowel bladder. When it comes to the GI causes, again, lots of different stuff in the GI system, right? What I need to watch out for is I need to watch out for associated signs and symptoms. Big ones are going to be appendicitis. Irritable bowel syndrome is another big one we're going to see. But I also need to assess and screen for those things, right? So if I have pain that's increased with coughing, straining during a bowel movement, lifting, bending, that could be GI related. If I have pain that is associated with the iliopsoas abscess, obviously you guys know how to screen for that. These are rare, but they do happen. Crohn's disease and diverticulitis. We could have low back or pelvic pain as associated with ulcerative colitis, or what's commonly known as Crohn's disease. Again, we're going to see associated signs and symptoms with the GI system. So if they have underlying constant bowel pain that's not changed with activity, not changed with position. Again, remember, go back to the basics. It's probably not MSK, is it? It's probably something else. So just understand the associated signs and symptoms again. And I know I'm kind of repeating myself, but that's sometimes how easy this is. When it comes to the urogenital system, the big one we're going to see here are going to be kidney stones and UTIs. So be familiar with the signs and symptoms of a kidney stone or kidney infection. Be familiar with the signs and symptoms of a urinary tract infection. Again, are you having any bowel bladder changes? Yeah. Every time I use the restroom, it really burns. That's probably not an SI problem, right? That's probably something like a UTI. Just be very, very cognizant of all that. When it comes to, I need to send this patient out of my clinic, and I need to send this patient out of my clinic right now. If we see evidence of fracture, they're out of my clinic, right? If I see evidence of an infection, they're out of my clinic. If I see evidence of a neoplasm, they're out of my clinic. Good example is if that patient has right lower quadrant pain, that gets worse with the rebound test. I hate to make fun of this class, but don't put them on the treadmill, right? I mean, what's that going to do? It ain't going to make them better. If you suspect that there is an infection, absolutely send them out of your clinic, right? Think about what those associated signs and symptoms. The big one's fever, right? So if my patient has all these MSK kind of pain and this kind of weird achiness around their pelvis, but they have a fever of 101, there's a good sign that there's an infectious process happening. And if you suspect that potentially, and I've worked in clinics where they actually ask menstrual cycle questions on the intake paperwork. If you suspect there might be a pregnancy, they got to prove otherwise they're not pregnant, right? And that's a big one. So if I have a female of childbearing age that has pelvic pain, SI pain, hip pain, something of that nature, I'm going to ask them right away, is there a possibility you're pregnant? And if they say no, okay, when was your last menstrual cycle? If they tell me 3 months ago, that's not normal. Okay, I need to watch out for something like that because they could have an ectopic pregnancy happening. These are the guidelines for physician referral. Believe it or not, things like anal fissures happen a lot. They happen to folks that don't even know they have them, or something like hemorrhoids. This may be a case where you continue to see the patient for low back pain, but you say, you know what, I think you probably should go see your primary care physician so they can get you to see a GI specialist. If my patient has a history of cancer and they've recently took the cancer out, but within 6 months they're having a lot of back pain, pelvic pain, whatever, remember, my greatest predictor of cancer is a history of cancer. Okay, again, get that person out. Send them back to the doc, say, hey, can we take a look at this? Like I just said earlier, if I have a female childbearing age, I need to ask last gynecological visit, last menstrual cycle, are there any abnormalities with the menstrual cycle? I also need to ask sexual history questions. Final point on this slide, and this is a big one, and again, this is another really simple one. If I'm seeing that patient for low back pain, pelvic pain, whatever it is, and they're not getting better with therapy, again, why would I continue to see them? Or if I'm making them worse with therapy, why would I continue to see them? And I'm not talking about they're sore one visit. I'm talking like I've seen them for 2 weeks and we're steadily getting worse. Or I've seen them for 2 or 3 weeks and they're just not getting any better. There's a good possibility that you're not the right intervention for them. Take a look at past medical history. A lot of the stuff we've gone over many, many, many times. Clinical presentation when it comes to sacrum and SI joint. If they have something like a click or something like a catch with constant, really, really bad pain, there's a possibility they have a sacral fracture. Now, the reason I bring this stuff up, again, remember that we're kind of educating you, not based on where this profession has been, but based on where this profession is going. Very good possibility you're going to see this in the emergency room, or you're going to see this in urgent care, or a setting like that. So you will need to not only ask that patient, hey, does that hurt? And they're going to say, oh my gosh, does it hurt? Are you having any other feelings with it? Are you feeling anything else with it? Oh yeah, it really catches or clicks when I move around. Let's get a diagnostic image on that person. Let's get an X-ray. Again, sometimes what's going to clue me in that this person does not need to be in my clinic is not necessarily the presence of abnormalities, but remember, lack of objective findings is just as important, right? If I do range of motion testing on them and strength testing and reflexes, and I crank on the pelvis and do all those 4 like little fun tests you guys do, and nothing is eliciting their pain, then it's probably not MSK, or at least there's enough evidence to say, let's take a look at some other stuff. When it comes to past medical history, again, be very, very thorough. Did this person have bladder surgery? Did this person have colon surgery? Did this person have a cesarean section? That's good to know. How many childbirths have happened? Were there any abnormalities with them? Again, big one, as these devices are more common these days, intrauterine devices or IUDs. There is a pretty high correlation between the presence of an IUD and pelvic inflammatory disease. Pelvic pain is not going to be dissimilar, aka it's going to be very similar to other organs and other viscera that we have seen. Remember, if I have pain that comes in waves, and I gave you guys the example real early last year of you're on a really long road trip and you got to go to the bathroom, and it's like all of a sudden it goes from, I'm doing okay to, oh man, I really got to go to the bathroom. And then it kind of comes back down to, I'm doing okay, right? That is kind of a wave of pain. It kind of goes up and down in these waves. That's a pretty good indication that there may be something visceral in nature, aka non-MSK. If I see any abnormal discharge, or ask my patient, is there abnormal discharge? And they give me a sign or symptom of, you know what, yeah, there is something that kind of smells infected or looks infected. Chances are it's infected, right? And that does not only, that's not only specific to pelvis, but I always see it a lot with my post-op patients, right? My rotator cuff, my total knees, and what have you. To me, this is me personally, I check that incision every time they come in for about the first 3 weeks. Because my number one goal for that patient is not for them to get to an infection. When it comes to gynecology, if I see pelvic pain that's relieved by rest, putting a pillow under the hips, or getting off your feet, that might not be MSK, that might be more gynecological in nature. When it comes to the vascular system, again, if it throbs, that could be a good indication that it is vascular in nature. If I see temperature changes, and think about the aorta and how it kind of branches off into the common iliac arteries. If I have a common iliac artery occlusion, what I'm probably going to see is there might be some pelvic pain, because think about where that aorta branches out, right about L5S1. But then I'm going to have an entire leg that's cold, shiny, right, because it's not getting any sort of arterial flow. When it comes to the sacrum and SI joint, if I have pain, remember, where it refers to is just as important to where the pain is. If I have pain that refers upward, it's probably not the SI joint. It's probably coming from something like discogenic in nature. If I have pain that increases transferring sit to stand, then I might be more discogenic. Big things to watch out for are going to be things like Reiter syndrome, ankylosing spondylitis, right? My suggestion, not only because you guys have a midterm coming up next week, but also because you guys are going to be PTs here in a little while, watch out for ankylosing spondylitis. I've had several cases of it in my career. Be very familiar with that modified New York criteria. Okay, so if you don't know that modified New York criteria, know it. Understand that I can have pelvis and low back pain at the same time too. Okay, and that's very important to remember. There's going to be a lot of times, and you guys have probably already seen this in the clinic, ask the patient where it hurts. Well, it kind of hurts all the way around my waistband, right? Who's had a patient like that so far? Or it hurts all the way around my belt line. So I can have low back pain, and I can have pelvic pain. It does not necessarily mean that it's something GI or gynecological in nature or anything like that. It could just be something like quadratus lumborum or one of the obliques or something is not doing well, it's dysfunctioning. If I see signs of infection though, yellow-green odorous discharge, fever, things of that nature, that's probably not quadratus lumborum, it's probably something else. Remember, if I see something that's bilateral, that's not normal. Okay, and that's going to go for a lot of different things. So anything that's bilateral is typically going to be something that's more systemic. I could see bilateral iliopsoas abscesses. It is rare. As you guys know, appendicitis can refer pain from the right lower quadrant to the left lower quadrant. Sometimes the pain will move back and forth. So just be very, very careful and very thorough when asking patients these questions. All right, the next couple of slides is going to get to more imaging. First couple slides are specific to the hip, okay? So we're going to get into the hip after the midterm. So don't worry about these next couple of slides just yet. Later on, we'll worry about them. All right, there's your pelvis. Oh, it's great. Wondrous nature. So there's only a couple of views for the pelvis. Big thing to remember here, we're going to use an AP view, and then less common, you might see something called the pelvic inlet view and the pelvic outlet view. What you're not going to see is a lateral view of the pelvis, and it makes a lot of sense why, right? If I place a patient on their side and try to do a lateral view, I'm basically going to get a nice big shot of one ilium, and that's about it. Because the other ilium is going to sit under the first ilium. Like I already said, the pelvis is a very dense bone. Therefore, it's going to absorb a ton of radiation. This is also why I need to be very, very selective and careful on who gets x-rays and who doesn't. Because if I have a patient of childbearing age, and I'm going to subject them to the amount of radiation that goes into a pelvic x-ray, I better have really good evidence why I need to do it. Because there's going to be a risk that I'm going to damage reproductive organs. I don't want to do that. This is what the AP view looks like of the pelvis. Big things to remember here. Okay, we're going to get into this, especially when we start covering the hip. Lower extremity position in terms of internal and external rotation is going to be very important. Normal AP pelvis, normal AP hip, legs are going to be extended and internally rotated 15 to 20 degrees. What that does is that places the femoral necks, quote, parallel to the image plane or perpendicular to the direction of radiation. Now, why do we do that? Because if I internally rotate both femurs, I can see the entire femoral neck. Okay, so that's just a really fancy way for saying I can see the entire femoral neck. Most folks, when you lay them supine anyway, are going to lay in a little bit of external rotation anyway. So if you think about it, the femoral neck is going to slide back a little more out of the frontal plane and into more of the sagittal plane, which is going to obscure the image. I'm not going to be able to see the entire femoral neck. With the amount of femoral neck fractures that occur, I want to see that entire femoral neck. This is what the AP looks like of the pelvis. This is the nice thing about doing an AP pelvis. I can see a ton of stuff here. I can see the entire pelvis. I can see a good bit of the sacrum. I can see those SI joints. I can even see the proximal 1/3 of the femoral shaft. And I can see acetabulum, femoral head, femoral neck. And if you look real closely, I can even see the lesser trochanters. So pelvic APs are nice because I can see a lot of stuff. The pelvis is a little bit of an enigma because I can kind of get a second view because remember, like we talked about, one view is no view, right? So I can kind of get a second view here, but it's not going to be at a 90-degree tangent to the first view. So I won't get a true 3D representation here. Those are the lines that we look at for symmetry. So what I want to make sure is that both ASISs are aligned with one another, aka there's not one higher than the other. I also want to look and make sure that the body of the sacrum, the midline of the sacrum is right where the midline of the pubic symphysis is. I want to make sure that both obturator foramina are in line with one another. And I want to make sure that the roof of the acetabulum is fairly in line as well. Again, this is really, really good to know for testing purposes. In fact, I think one of the quiz question that some of you emailed me about, and I had all sorts of problems, but I finally fixed. Labeling the pelvis is going to be very important. As you guys know from previous midterms and finals in this course, there's going to be some labeling questions. So make sure you know things like this. So number one is going to be my iliac crest. Ala of the ilium is going to be number 2. Ala just means wing, remember, from anatomy. Number 3 is going to be my sacrum. 4 is going to be the roof of the acetabulum. 5 is going to be superior ramus. 6 is going to be my pubic symphysis. 7 is going to be inferior pubic ramus. 8 is going to be my femoral head. 9, femoral neck. 10, greater trochanter, right? So pretty easy, pretty simple stuff. This is the difference between the male pelvis on a radiograph versus female pelvis on a radiograph. Obviously, what we're going to see here is with the male pelvis, iliac crests are a lot higher. The bowl of the pelvic ring, if you will, or the bowl of the pelvis is a lot more narrow and deeper. It has a very narrow pelvic outlet. The female pelvis, iliac crests are not nearly as prominent or as high, and it has a wider pelvic outlet. This is even though it looks really funky, like if you look at this and you don't know what you're looking at, it looks like this person has absolutely obliterated their femurs and their pelvis, doesn't it? What this is simply a skeletally, immature pelvis. This is on a kid. All you're really seeing here is the lack of mineralization at the growth plates or the epiphyseal plates. So don't let x-rays like this freak you out, because look at the patterns, right? So if you look at it superficially, it looks like this person's obliterated their pelvis. Look at it a little more closely, and especially those femoral heads, they have a pretty even gap in between the head and the neck, or the head and the shaft, I should say. Same thing with the ilia, right? There's a pretty even gap there. So this is a skeletally immature pelvis. When it comes to pelvic trauma, typically what we're going to do, first line of defense is going to be the AP view, because remember, we can't do a lateral. And then if there's something that we're really not sure about, or we think something else is going on, CT scan. Okay, so that's going to be very different from some of the other parts of the body that we've done. Remember, we've kind of talked about AP and lateral or AP and oblique being done, and then another study. Because the sacrum is such a unique object, we're going to go AP, and then if there's something else funky going on, or we're not sure, we're going to go straight to CT scan. What we're going to look for are going to be something like ankylosing of the SI joints, what we call sacroiliitis or sacralization. We're going to look for those ABCs like we went over the very, very first section. I will mention midterm-wise, there's going to be some very basics of radiology, things like the ABCs, things like what's going to show up darker or lighter, or things like that, because I want you guys to kind of review that material as well. So understand that very, very basics of radiology will appear in that midterm as well, because I want you guys not to forget that stuff, because it is important. If I see displacement of one SI joint or displacement pubic symphysis, that's going to be really bad. That shouldn't happen. Or obviously elements of fractures. What I should see at the pelvis, and especially the pubic symphysis, I should not see a diastasis. I should not see a separation. Remember, you guys probably talked about already diastasis recti, separation of the rectus abdominis. I can see a pelvic diastasis, but I need to put that in the full context of the patient. So what I could see, honestly, is anything over 1 centimeter is considered abnormal. However, let's think about it. If that female just gave childbirth, okay, I'm probably going to see more than 1 centimeter because of the shifting that happens during childbirth. It takes a few months for that actually to go back in place. If I see anything 2.5 centimeters or more, remember 2.5 centimeters, 2.54 centimeters equals 1 inch. I mean, heck, that's a heck of a gap at pubic symphysis. Then what I could see is not necessarily only pubic symphysis problems, but I may see ligamentous damage at the SI joint as well. Because remember, it all operates, the pelvis that is, all operates in one big ring. When I see fractures, this is a big one to remember. Pelvic fractures typically do not only happen in one place. And the reason is because typically with pelvic fractures, there's going to be an explosion, okay, or an outward force forcing that pelvic ring apart from one another. I typically will see 2, 3, 4, 5, 6, maybe fracture lines with a pelvic ring fracture. This is big to remember because some of those may be very evident and some of those may not be very evident. But with pelvic ring, typically I'm going to see more than one fracture line. Pelvic fractures are also very important and very dangerous because of the proximity of the urethra and the bladder. If we think about it, if I have a really bad pelvic ring fracture and one of those little fragments of bone sticks into my bladder, I'm going to have a bad day. So we need to be very aware of these things. When it comes to the posterior aspect of the pelvic ring, the best imaging modality is going to be CT scan. And we kind of saw that when we looked at the AP X-ray. AP X-ray was pretty good about looking at things like pubic rami and the ala and things like that. When it came to posterior side, it ain't so good. CT is going to be my #1 modality for the posterior ring. Reason being is because I can create a 3D image, or I can create an axial image of the posterior ring or any other structure by the nature of the CT scan. Remember, CT scan is just a whole bunch of X-rays. So this is a fun little one. So we had a patient that suffered a diastasis after a parachute injury. That's what it looks like in AP X-ray. This is a fracture of the inferior pubic ramus and initial tuberosities. Tuberosity, I should say. So draw it out here. There's your fracture. That would be somebody that fell on a buttock or was involved in a motor vehicle accident of something of that nature. That's a comminuted fracture of the left superior pubic ramus. Remember what the definition is of comminuted fracture. I have many, many fracture pieces, or AKA more than 2. And you get a good appreciation for, take a look at that fracture and its lines. Think about the amount of structures, the amount of anatomy that's right there, right? Bladder's right there. I got a lot of structures, both from an MSK nature, because obliques, remember where obliques attach, pubic tubercle, pubic crest, everything from that to the structures inside my inguinal canal, things like spermatic cord or round ligament of the uterus. So that's why these are so important. So what this X-ray is showing is a prior avulsion fracture of the right ASIS. It healed, but it didn't heal all the way. So there's your fracture. This could pose problems, or this could be just something we find kind of fun on an X-ray. It happens. Believe it or not, there's a lot of folks that go in and they'll have a clavicle X-ray done. It's like, hey, did you ever break your clavicle? And find out they broke it when they were an infant or something. When it comes to stress fractures, the pattern is going to be overuse, right? We're going to see this a lot in folks that increase training a bunch all of a sudden. If they get off their feet, go into a non-weight bearing position and have relief, that could be indicative of a stress fracture. If they don't know how they got hurt, or it's very gradual in nature. Typically what we're going to do, X-ray is not going to show us a bunch when it comes to stress fracture. MRI, bone scan, that's going to be our key indicators. Okay, so if we have a lot of evidence of a stress fracture, we want to go straight to an MRI because X-ray is not going to show much. That is what an X-ray is going to show in terms of a stress fracture. I can tell you that that's a really, really bad one. Why? Because it's actually showing up on the X-ray. Typically, they're not going to show up like that. This is a really bad one. And this is one that's already started the healing process. And you can tell that because there's that little cocoon of bone that's kind of formed around. In terms of sites or locations, inferior pubic ramus is going to be our most common site for pelvic stress fractures as well. As you can see, this one is a bilateral stress fracture. This one's on the healing side of things. It's actually getting better. We really, if you're just glancing at this, you really can't see much. Like if I took the arrows away, it'd be a little more difficult to see where the fracture is. But what we can see is increased activation, increased calcium absorption, aka the B in the ABCs, increased bone density, is evident of this radiograph. Now, put that person under a bone scan, and I can see that stress fracture pretty readily. And this is why, when we have evidence that there may be a stress fracture happening, MRI bone scan is going to be a much more sensitive, much more specific imaging modality than an X-ray. X-ray, I'm going to need to see a ton of bone loss before it's actually going to show up. On MRI, that's what MRI is going to look like. Okay, so I can see a large area on the pubic ramus where I see a bright spot or a white spot. That bright spot or white spot is going to be indicative of increased activity. So again, pelvic stress fracture, I want to go straight MRI, straight bone scan. You can use X-ray for it, but unless it's really bad, it's not going to show you a whole lot of anything. Last slide or two is going to show you Paget's disease, and then we're going to go into what's called a Ewing sarcoma. So, like I said, Paget's disease is this odd metabolic disease where the bone doesn't go back to where it's supposed to go when it resorbs. And what we have is we have these, literally, you'll see them, these big fluffy areas of bone. It is very, very rare, but it is something that we do need to screen for. So like I said, the pelvis should be very dense, very white. The bone density should be very, very great when it comes to the ilium and the pubis bone and the ischium. What we see here is we see a lot of radiolucency in the trabecular bone of the pelvis, right? Like I said at the very beginning of the class, I can almost see all the way through that thing. That's not good. That's not good at all. If I can see through someone's pelvis on an x-ray, that means there's not a whole lot of bone there. And that's why Paget's disease is so scary, because that person could have a very serious fracture from literally doing nothing. Ewing sarcomas are going to be more indicative and more prevalent in children. So if we have this child that comes in with this pelvic pain, SI pain, hip pain, whatever it is, and they're showing some kind of weird signs and symptoms, we probably need to get them in and screen them for a Ewing sarcoma. They do happen in children, not a ton, but they do happen. And then in adults, we're not necessarily going to see a Ewing sarcoma. We're going to see something called a chondrosarcoma or osteosarcoma. And as you can see from the x-ray, we have an increased area of bone density on the left side of the ilium. So the big scary part is if I see a pelvic sarcoma, there's a high correlation with metastasis, which means I need to go look at other spots, and that's not a good situation. All right, guys, that is all we got. I will see everybody next week for the midterm. Everyone have a really good rest of your day.